Welcome, everyone. We are going to have a very interesting episode as we are diving to exercise oncology, which is the use of exercise in cancer prevention, control, and survivorship. This episode is about cancer, but it helps us understand in general how beneficial movement is for humans and how it can be used even in situations when you intuitively think individuals should not exercise. And we have an amazing guest for this episode. She is the Associate Director of Population Sciences at Penn State University College of Medicine and jointly serves as full professor at the University of Pennsylvania, US. She has published more than 240 peer-reviewed scientific papers and has had over $25 million in funding for her research. She is one of the most cited authors in the field of physical activity, and her popular book, Moving Through Cancer, is a landmark in exercise oncology. Ladies and gentlemen, please welcome our guest, Professor Kathryn Schmitz. Welcome, Kathryn.
My goodness, I must be Methuselah to have done all of that. Thank you so much for that kind introduction.
Yeah, thank you for taking time for this podcast. So if we start, how did you came to specialize in exercise oncology?
So I actually did my PhD with a cardiologist and was, trained in looking at the benefits of exercise for cardiovascular disease prevention and other, treatment outcomes, as well as obesity treatment and prevention and metabolic disease. And I was funded to do my very first randomized controlled trial in midlife women to see if we could prevent the increases in fat that occur in women as they age by doing twice weekly strength training. And so I was headed down that direction and doing that trial. And I was, sort of had in the back of my mind that, a lot had already been done in these areas. And not that there wasn't more work to do, but a lot of work had already been done. The landmark studies had been published. And so the question was, where, what's my niche, right? And I had a faculty mentor. I was a postdoc at the time. I had a faculty mentor who asked me to consider doing some reading and seeing whether I might be interested in working in cancer. And so, when you're a postdoc, you have time to, just, stop what you're doing and do a deep literature search. So I did. And it didn't take that long because the literature just wasn't that deep in exercise and cancer at the time. And I came across a paper that was written by Dr. Ann McTiernan from the Fred Hutchinson Cancer Research Center in Seattle in 1995. And I came across the paper in, I guess, about 1999, 2000. And the paper was a call to action. And it was a call to action to people with exactly my type of training to say, hey, please think about coming over here with us in the oncology field and working on exercise and cancer because there is an awful lot to do and you'd really be getting in on the ground floor of the field. So the next grant I wrote was to the Susan G. Komen Foundation. And I got the grant and started to work in exercise oncology and never looked back. So it was really all about literally one paper that changed my direction of research. I was bold and wrote Dr. McTiernan an email and said, I really liked your paper and I'd like to take up your call to action. Any tips? And she was so kind. And she sent me some of her grants to read and read some of mine and was helpful to me in ways that are now as a senior investigator, just kind of unbelievable how much she did. She was so important to the founding of this field. So I got really lucky with some mentorship too, I guess.
Yeah, that's a nice story. And I saw your presentation in YouTube at Nobel conference, and in that you provided a historical perspective for cancer and exercise oncology. Would you like to share that perspective of
Sure,
history?
absolutely. I actually think it's kind of fascinating. I got the opportunity to look at this history because of the first book that I wrote, which was called Exercise Oncology, which was a compilation. I edited this book, and we got the best and the brightest in the field to contribute chapters, and it was intended to bring together, what do we know right now about exercise and cancer. And so I wrote, as an introductory chapter, a history of exercise oncology. And so I learned that the phrase was coined in 2007 by probably Kerry Cornier, and who's in Canada, University of Alberta. And if you go back in history, and I did sort of a deep dive to sort of say, how far back can you go and find literature that helps us to connect exercise and cancer? And the answer, as far as my literature search revealed, was 1911. There was a paper by Dr. Ewing that showed that it was in the beginnings of the Industrial Revolution, and so there were people who were sort of upper class, people who didn't have to do manual labor anymore, and then there were people who were still doing manual labor, and what they noticed was that cancer rates were higher in people who were more sedentary, and who were thus more likely to be obese. So that was sort of very early days. But there's this very interesting smattering of papers that have in animal models that happens throughout the 20s, 30s, 40s, 50s, and even 60s. Many of which entered into the question of exercise and cancer by assuming that exercise would be bad for the animal, that exercise would be a stressor for the animal. And there was one particular set of studies that was done at a cancer institute in Philadelphia, not Penn. They said, we used exercise as a stressor, and we were interested in showing that stress causes cancer. And so imagine their surprise when repeatedly in their studies, what they found was that the exercised animals were less likely to develop cancer. So there were all of these, observations in animals. I found these, sort of recommendations for the exercises for the mastectomy patient from Memorial Sloan Kettering, from the 1950s with, a pictured woman with an A-line skirt, like the bathroom, you think of the, what you see as the picture of an outline of a woman on the bathroom door, at least in the U.S. They had, recommendations of all of these range of motion activities and swimming, which frankly is still really outstanding advice. Then they're really the first human trials of exercise and cancer were done by Winningham and McVicker, who were nursing researchers at the Ohio State University, and they did these studies in the 1980s. And when I think about what they did, what they were undertaking, and the time that they were doing it, it was radical. They were asking women who were undergoing chemotherapy to do vigorous cycling exercise, stationary cycling exercise, during their chemotherapy. And, vigorous exercise, not just taking a walk, there's actually, the recommendations now would not have us prescribe vigorous exercise at that time. But what they found was that it was helpful for nausea, it was helpful for fatigue, it was helpful for anxiety. It helped with changing, body composition in a positive way. So, but then in 1996, there was a review of the literature. This just cracks me up today. Just to think about the thousands of papers that exist now, but there was a review that was published by Kerry Cornier and Christine Friedenreich in 1996 that reviewed all four of the clinical trials that had been done to date, and they concluded, not surprisingly, that more research was needed, and that there were, limitations to the research that had been done. But they were, prescient, both of them, and they even then were starting to see the value of creating kind of a way of organizing our thinking about exercising and cancer. And so developed not long thereafter something called the PEACE framework. And that's taken different names at different times, but PEACE is physical exercise across the cancer experience. And although it has revised by name and a little bit over time, the basic idea is that if we are going to try to study exercise in the realm of cancer, then we really need to think of it in different buckets of the cancer experience. So there's primary prevention, and then there's thinking about what we might do for somebody who's been diagnosed but hasn't started treatment, which we now call rehabilitation. What we would do for people who are currently undergoing treatment, immediate post-treatment, and long-term survivorship, or palliation and end-of-life care. So, so they drew that out, way before there were the trials to tell us that, in fact, yes, we needed to be paying attention to time course. So it's kind of remarkable what they came up with. By 2010, we had the first ACSM Roundtable guidelines for exercise and cancer, and they were in retrospect really mostly about what you shouldn't do. They were mostly about safety and trying to prove to the clinician and patient that it was safe to exercise during treatment. The more recent ACSM guidelines from 2018 are more specific, much more specific about, what kind of exercise one would do for very specific outcomes. And there are additional guidelines coming in 2022 from other organizations. So I'm not sure I'm at liberty to say, but stay tuned. There are more guidelines coming for exercise.
So basically quite interesting points in the history. First, it was thought that it's a stressor and that it increases chances of getting cancer. So there's been some paradigm shifts. Do you see some parallels of history of exercise oncology to prevention and treatment of other health conditions? I think with many other things, it has gone in a little bit similar way. Do you see any parallels?
Oh, absolutely, and so the storyline that I think is most salient here is cardiovascular disease, and although back pain, pregnancy, the idea that we tell patients that rest is best. Is historically what we do with most health conditions. When in doubt, tell the person to rest. That's kind of been the case for many different chronic diseases. And in heart disease, some of the most amazing work was done in your neck of the woods in Scandinavia, in Sweden in particular, and there's amazing studies that were done at Karolinska, just simply getting patients to sit up. And if we got people sitting and in chairs quicker, then, it was stressing the heart just enough that men, it was mostly men being studied, were better able to get out of the hospital quicker, which pleased the hospital administrators. And so, my mentor, Henry Blackburn, was instrumental in some of those very, very early studies. And so literally that was sort of the genesis of moving us in the direction from, the stepwise direction from, rest is best and lie down, rest and lie down, to exercise and cardiac rehabilitation. Literally the first step was have them sit up. That literally was the first step. And it took decades to get from that to what we now recommend, which is you should be recommending exercise soon after a cardiac event or a cardiac procedure and getting somebody into a cardiac rehabilitation program as soon as possible. One of the things that I think is important to point out based on your question is that required not just a shift and a growth in the scientific evidence base. It required a shift in the culture of that disease, around that disease. So today, if you ask the average person with a high school education in a westernized country if exercise is good for their heart, they're probably going to say yes, because there has been a culture shift. So people know that exercise is good for heart disease, whether you have it or you're trying to prevent it. If, on the other hand, you say, hey, your Aunt Betty has bladder cancer, should she be exercising? They'll probably say no. They'll probably say no, she should be resting with a blanket over her knees. And, it's hard enough to get through this treatment. It's hard enough to survive cancer. So we have a culture issue, and we need to figure out how to shift that culture, because I think that many patients and survivors would be very surprised, especially those that are less well educated, would be very surprised to learn that the evidence base is extremely robust to show us that patients who exercise before, during, and after their cancer treatment are much more able to survive their disease, and they have a higher quality of life and better function. They're better able to return to work. There are a variety of mechanisms for this, but the benefits are broad and long lasting. And so, how do you change that culture? And maybe that might be one of the reasons why I agree to do podcasts. So.
And where do you think we are in that cultural shift? I think now there's a consensus among researchers that exercise is good. Is it already within the clinicians? It's probably not yet with the public. Where are we in this culture change, in your opinion?
Yeah, I think that that the researchers know, and I think we're there with the researchers. I think that the clinicians, I think that there is variability. It's sort of an interesting question you've asked, because the American Society of Clinical Oncology did a survey of clinicians to ask, what is important? Is it important for your patients to, eat well, maintain a good, healthy weight, exercise, healthy behaviors? And I believe that I don't remember the exact number, but it was near 80% said that yes, exercise is something that patients should be doing before, during, and after their treatment. But that might be a biased sample, in that who's going to answer that survey? Is the doctor who thinks that exercise and healthy behaviors is nonsense going to answer the survey in the first place? So, so I can tell you, I live and work in a relatively rural setting in Pennsylvania, in the U.S., and at my institution, I would say about 60 to 70% of clinicians are on board. And when I talk to clinicians in the community who are not in academic medical centers, I'm going to guess it's more like 40%. So I think that there's variability in how much this research and the research findings have disseminated to the clinicians. When it comes to the patients, I think that well-educated patients that get themselves on the internet, and the ones who, are looking at what we jokingly call Dr. Google, and want to know everything about their disease, I think they know, and I think they understand. And I can tell you that the less well-educated and or rural patients, low-income patients, are much less likely to understand, A, that it's safe, and B, that it would be good for them. And so therein we have this sort of catch-22, right? So if you have people who are lower income, lower resource, lower education, where are they going to be, and who's going to be treating them? It's much more likely to be in the community setting, where the oncologists are less likely to have gone in.
Mm.
So they're not hearing it from their clinician. And we have evidence, there's published evidence, that a lack of saying anything about exercise to cancer patients while they're undergoing treatment and afterwards is taken by cancer patients as not just permission, but a mandate to be sedentary.
Mm.
So we need to educate those clinicians. So figuring that out is a puzzle.
Yeah, so still quite a bit of work to do. What do you see as the biggest obstacles, and how to overcome those in this change?
Yeah. So I am the founder of an initiative that is interested in this exact area. It's called Moving Through Cancer. It's the same name as my book, my second book, and we have 5 agenda items, and one of them is stakeholder awareness and engagement. And what we mean by that is exactly what we've just been discussing. How do we get more clinicians bought in? How do we get the patients to understand the value of exercise before, during, and after their treatment? And it's one of the reasons I wrote the Popular Press book. Because now there is a book on the shelf in bookstores and on Amazon that is intended to be written for the person who has been diagnosed with cancer, and their brain might be a little foggy right now, frankly. So it's written at a very easy reading level, and it's written with the program being very, very simplistic on purpose in order to help people to get through their treatment. So that was item 1. Item 2, we recently acquired some funding to do a stakeholder awareness campaign, and we have developed an infographic and an accompanying brochure. We're working on the graphics and trying to fix it and make it exactly what we want it to be. And then the question is, how do we distribute it in a way that gets it to the clinicians and the patients who most need it. And it's sort of have you ever seen sort of videos or pictures of a baby that doesn't want the food, and they're kind of I mean, how do we deliver this in a way that is makes it easy for them and makes it palatable? So one of the things that I've been interested in that we haven't done yet, but I'm very, very interested in doing, is the development of a CME, continuing medical education webinar that is very, very simple, that takes them an hour and would allow them to check a box for, they have to do continuing medical education credits. They have to, right, in order to keep their licensure. So if we could provide something and provide it for free, we need to develop it and we need to get it accredited by the AMA and, European sources, all over. But then if we can, publicize it, then, can we do kind of an exercise in cancer 101 that makes it easy for the clinicians to see the benefits to their patients of simply telling their patients, it would be okay if you did some exercise, or it would be great if you did some exercise. So how would they talk to their patients about it? What would they say? We've actually developed something that is a much longer course that is called Active Conversations, that is based in motivational interviewing and answers the question, but I don't know what to say to my patient, right? And so we've partnered with an organization in the UK called Moving Medicine, and we have this beautiful course, and there will be CMEs, and it's not expensive, and we'd like to get some sponsorship for this. But what we've recognized is that we kind of went to step 2 without going to step 1 there, right? Because when we try to ask clinicians to do this course, the only ones that want to do it are the ones that have already